I'm Christy Turlington-Burns, the CEO and founder of Every Mother Counts, and it's a privilege to be with Frontier today for this virtual event. I often tell people that I became a global maternal health advocate the day I became a mother, and with that, it is implied that any mother could consider herself one too. For the last nearly 15 years, I have been sharing my birth story with friends and strangers alike, in hopes that in doing so, other women will be better prepared for their entry into motherhood. I gave birth to my daughter Grace on October 23, 2003. I was healthy before and throughout my pregnancy and had plenty of provider and facility options to ensure the birth experience I had always imagined for myself, an unmedicated one. My husband was totally on board with that and supportive, and together we chose our very capable midwife, Elizabeth Boyce, to deliver our first child and second in a hospital birthing center just a few miles from our home. We took all the additional classes and responsibility required to give birth in a birth center. And as a result, we felt so well prepared for everything. That is, everything but what occurred after Grace was born. My placenta was retained and could not expel itself, so it had to be removed. As a result, I lost a few liters of blood. And while the active management of this complication was painful, I never feared for my life because I had confidence in my midwife and others who worked together to stabilize me. Without access to this critical and timely care, I may not be here today. Many other women are not as lucky. Soon after Grace's birth, I learned that more than 500,000 women and girls were dying each year, and that number had not come down in decades. I was shocked and outraged. I spent the next few years sharing my birth story and all I was learning about the leading causes of complications and death for women around the world. In 2005, I traveled to El Salvador, my mother's birth country, with an international NGO while pregnant with my son. While visiting programs to see how they were addressing maternal mortality, I met other mothers. It was on this trip that I became more familiar with the Millennium Development Goals and learned about which countries were making progress and what models were most effective. It would come as no surprise to me that midwives were cited as one of the best ways to improve maternal health and birth outcomes and prevent maternal deaths and complications related to childbirth, because I had experienced what quality and respectful maternity care means, and it kept me safe. That's all I needed to become personally invested, but everything I had learned since becoming a mother is what inspired me to go a few steps further. I pursued a master's in public health and started production on a documentary film called No Woman, No Cry in 2008. The convergence of these two endeavors allowed me to continue to learn and apply that learning to all that I saw in the field, and provided me with ample opportunities to meet more mothers and women, plus a wide range of maternity care providers in Tanzania, Bangladesh, Guatemala, and the United States. When the film was completed in 2010, I continued to travel with the film for 2 years, campaigning for improved access to basic and emergency obstetric care, highlighting the stories behind the statistics, before I realized that the film was just the beginning and that there was so much more to do. I founded Every Mother Counts to raise awareness and engage communities. Since 2012, we have invested in community-based organizations working to improve access to quality and respectful maternity care, including by educating new midwives. Today, we have 13 grantee partners in 7 countries. From the US to Haiti and Guatemala, many of our grantee organizations are led by midwives and are focused on strengthening the care provider gap. We have made over 20 films to highlight the people and the programs that we support, as well as the state of maternal health in the countries where we work. We inspire people to use their voices to advocate for quality, respectful, and equitable maternity care for all. And I'm excited to introduce to you Nan Strauss, our Director of Policy and Advocacy here at Every Mother Counts, who will share more strategies to advocate for increasing access to midwifery. Thank you.
Thank you so much to Frontier Nursing University for inviting me to participate in this virtual event, and to all of you for joining me here today. Thanks, Christy, for that introduction, and especially for sharing your own experience with answering the call to service and talking about what inspired you to become an advocate for women and mothers around the world. I'm going to be talking today about maximizing midwifery, strategies to expand access to the midwifery model of care. We know from looking at maternal and infant health outcomes and from the experiences that women recount to us that the healthcare system in the United States is not meeting people's needs in pregnancy and childbirth care. At the same time, substantial evidence supports the midwifery model as a proven strategy to improve outcomes and the experience of care and to use resources more effectively. My background is as a lawyer, and you're all nurses and midwives or studying to become them, so I thought I should come here and tell you about midwifery. Not really. Many of the things that I'm going to talk about today you might be familiar with. They might even be old hat to you, but I want to bring that information into a different context. So first, I'm going to talk about some ways to think about advocacy. Then I'll go into greater depth in using the evidence behind the midwifery model to develop a persuasive argument. And we'll also talk about some of the barriers standing in the way of greater utilization of midwives. And hopefully this discussion will offer a new way to think about the issues or to frame them for a wider audience, particularly when persuading policymakers, decision makers, and others to seriously consider how to integrate the midwifery model and midwives into the healthcare system. Also, I've included a lot of really nice photos of midwives and student midwives, so when you get bored with the presentation, you can always look at those. Following are some tools that hopefully will be really useful to you in developing your own strategies for advocating on behalf of midwives and midwifery, so that in addition to your call to service as a clinician, you'll be prepared to answer the call to service by advocating for change. So what is advocacy? Let's get started. A traditional definition of advocacy is speaking on behalf of someone else, like what lawyers do or lobbyists. But this definition does not encompass the notions of power relations, active participation in decision-making, or social justice. A very neutral definition of advocacy would be public support for or recommendation of something you believe in, a cause, a proposal, a recommendation, or policy. But what I want to keep in mind today, and what I always use in my own work, is really a social justice framework that seeks to ensure that people, particularly those who are most vulnerable in society, are able to have their voice heard, defend and safeguard their rights, and have their views and wishes genuinely considered when decisions are being made about their lives. And that's what I want us to keep at the forefront of our minds today. And I should note that this definition comes from where I do all my most rigorous research. It comes from Wikipedia. So I had to keep it though, because it was actually a very good definition despite its source. All right. So at the outset, I just want to make a note of some of the paths that are available to making change. Some of the activities you might want to engage in at some point. Opportunities include influencing change through education initiatives, where you can really work with any community on changing attitudes and beliefs, work on increasing the political will, and really making sure that people are motivated to make the changes that we know are so important and needed. Also, you can work on initiatives oriented specifically toward fellow professionals, professional organizations, initiatives at a facility level, or working with educational institutions, either midwifery, but also medical schools. One can also make a lot of change working with policymakers, the people who make the big decisions at the top level, which that can be working to pass specific legislation, but it can also be working on a more intimate level, working on advising or working on regulatory issues behind the scenes. One of the most important strategies that probably I should have put first is community building. It's one of the most important avenues, and it's really important to think about mobilizing people because there's so many more people out there in the world who've had experiences with midwives than there are midwives. And there's so many former and current midwifery clients who feel passionately about what having a midwife has meant to them. And they feel passionately about sharing that experience with others as well. So take advantage of those numbers. There are also opportunities to make change in a less public way, like individual meetings, and those can even be with payers. Some of these efforts might be large scale, like payment reform initiatives, which can be very complex, very technical, and take a long time, but some might be really small changes, like changing how midwives are listed in insurance directories. So, where to start? I like to use a framework of who, what, where, when, how, and why as a jumping off point. You can pretty much fit anything into those questions, but it seems to work. So let's start with who. Who is the advocacy community that you're starting with? The next question really after that is, who else needs to be at the table? Outreach to underrepresented groups needs to happen at the very beginning of your work. It also can't be just passive inclusion or even active but limited to inclusion. What's essential is really demonstrating a commitment and making participation at the decision-making level right from the beginning a core part of the values of whatever effort you're involved in. It'll make it much stronger, much more effective in the long run. And looking in concentric circles out from the core group, you want to ask, who are your allies? Who outside of your core group would also be invested in the change that you're seeking to make? When you expand supporters, there can be benefits and costs. The benefits can be the numbers of people involved, the variety of perspectives and experience, but you do want to be aware of costs of the time it involves to grow and expand, and retaining the focus on what your initial priorities are. But often there can be gaps that other people and other organizations can fill. In order to really make those relationships work, you have to focus on being a respectful partner and ally. And that means giving as much as you are getting. It's often really important to also seek inside champions. Those people may have additional influence in terms of the targets that you're trying to affect, and also they can be very useful spies and get you inside information. But seriously, they can provide a very helpful perspective on the details and nuances of what's going on that may not be visible to people outside. Involving people early on, being transparent, and working hard to collaborate is essential. People want to feel that they have a stake if they're going to invest their effort in an initiative. So once you know who is coming together, you want to be able to identify what are the strengths of this group, what motivates this group, what does the group share in common, and you can develop a lot of strengths and opportunities simply by talking to the people who have come together and asking your colleagues what connections and influence people have, what expertise is represented, what skills are represented. So let's move on to the question of what. What is the specific goal? Is it how to increase access to midwifery? And if that's the broad goal, is that going to be reached through hospital policy changes, through changes to state licensure laws, by educating the public and increasing demand? Or it could also be something much more specific, like an initiative on safe prevention of the primary cesarean, expanding access to freestanding birth centers, or establishing a site for centering pregnancy. And you can refine those decisions by asking yourself where the greatest opportunities are. A number of the questions that you might want to consider in weighing those factors are: what's the severity of the problems and the barriers that you're seeing? How great is the need for particular change? How likely is it that your effort will be successful? How great of an impact can you have? And that can be measured in different ways. It can be measured in numbers, in the value to the community, in something else, lives affected or severity of the issues being addressed. And it can't be overstated that you really need to think about what you feel passionate about, because advocacy is hard. It's hard work, and it's usually a long haul. So if you don't feel really passionate about the goal, it's hard to sustain the effort, and it can lead to burnout. And finally, you want to look at where you are going to add the most value. Does that mean filling a gap, adding a particular perspective and voice or expertise? The next question is where? Where are the relevant decisions made? Where will you need to direct your efforts in order to be effective? You want to target the decision makers on the topic that you've chosen, the people who have the power to make those decisions. Or conversely, do you want to target the people in your community who in turn will pressure the decision makers who you want to influence? So for instance, if a problem involves licensure, that may only be able to be changed by the state licensure. But if you're tackling an issue where there's conflict among staff at a particular facility, then obviously you take a different approach and speak with and try to influence different groups of stakeholders. Once you know where your audience is, the next step to consider is what motivates them, what incentivizes them. Is it money or is it health outcomes? Is it efficiency and effectiveness? Is it patient satisfaction? Performance measure reporting or media attention? What would make those decision makers want to make the change that you're seeking? Those answers will influence the question of how, but first I want to talk about when, and this one is really the easy one. When will you have the biggest impact? What opportunities are there? So it could be that people will already be gathering together for a conference or for a community meeting, and you may want to join together as people are already gathered. Or it could mean remembering to avoid a time when some people won't be able to participate because the legislature's not in session, so you don't want to target the legislature then. Or it's a time of day when parents can't attend a meeting because it's pickup time at school, because it conflicts with religious holidays or commitments, it's election day, it's the Super Bowl, whatever it is. It's always important to take into account. So in thinking about how to move forward, the SMART mnemonic is a commonly used approach to narrowing down to define specific objectives that you're going to use to pursue overall broader goals. Are those objectives specific? Do they target a specific area for improvement? Are they measurable? Pardon me. Do they quantify or at least suggest an indicator of progress? Are they achievable? What's the likelihood of success? What results can realistically be accomplished given the available resources, both human and monetary and time? Is it relevant? Pardon me. Does it move you closer to the larger goal and mission? Or are you heading off maybe on a little bit of a tangent and you do better to refocus on your original goal? Is it time-bound? Can you specify when the results will be achieved? This is really important, not just because it keeps you on track, but also if you never see any movement or progress, it's really hard to keep momentum going. So now it's time to put this into action and think about the how. What is your campaign action plan going to be? What types of activities are you going to engage in? Who's going to participate? Who's actually going to make it happen on the day-to-day level? And how are you going to maintain momentum? What resources are needed? I have kept the question of why until last, because that is really where we're going to focus the bulk of our time. To be successful at creating change, you have to be able to not just explain the why, but you have to persuade other people to act, to put their energy, their political capital, their resources into what you're asking of them. The biggest why is, why are we been talking about maternity care in the United States? And I firmly believe that in any measure you can choose, maternity care is a no-brainer to be at the top of the list for healthcare reform and innovation. Every Mother Counts has put together a whole fact sheet on this, and it's available online because it's something that comes up a lot, and many people don't have exposure to this information. So some of what I usually emphasize is that this is a key priority no matter how you look at it. In the global context, the United States ranks 46th in the world in maternal mortality. And what makes that particularly galling is that we spend the most of any country on healthcare and on maternity care. Yet we have the worst outcomes of any developed country. In fact, we are the only developed country in the world where the maternal mortality ratio has been steadily rising over the last couple of decades. Maternal mortality disparities are among the worst disparities of any public health measures, with Black women facing 3 to 4 times the rate of maternal mortality as their white counterparts. And that disparity is even worse in some parts of the country. So in New York City, for where I live, for instance, Black women are 12 times more likely to die from complications of pregnancy and childbirth than are white women. It's also an issue that goes beyond mortality, because for every maternal death, there are 50 to 100 cases of severe maternal morbidity, complications that have the potential to be life-threatening. And at this point, that's risen to 1 woman every 8 minutes. So that means that in the time that I've been here speaking to you, 2 women in the United States have faced a complication of their pregnancy or childbirth that was life-threatening. And that may likely have lifelong consequences for them. If that hasn't convinced you yet of why this is an immediate and urgent priority, think about the fact that 100% of lives are affected by maternity care. If you aren't among the 84% of women who give birth at least once in their lifetime, we are all among the people who are affected by the care system at birth. Childbirth also is the most common type of hospital stay, and we spend more on childbirth-related care than we spend on any other type of hospital stay. True for private insurance, and it's also true for Medicaid. But if all of those factors, the huge scale of this issue, the severity of it, the comparisons with other countries aren't motivating enough, then maybe what will push you over the edge is that there's really a great likelihood that we can succeed at making change. We know what works. And now I want to make the case for why midwifery really needs to be part of that solution. The midwifery model is a well-studied, effective, high-value model of care. It's an evidence-based model to support optimal maternity care practices, and it results in safer, healthier, and more satisfying births, facilitates self-advocacy and satisfaction, it increases health equity, and it reduces spending. Midwives both reduce the overuse of procedures that carry the risk of harm and reduces the underuse of safe practices. Unfortunately, midwives themselves are an underutilized resource in the United States. Fewer than 10% of births in the United States are attended by a midwife, although the good news is that's the highest rate in 25 years, and it's increased from just 3.3% in 1989. But in contrast, we see that in many European countries that have much better maternal and infant health outcomes, about 50% of births are attended by midwives. And in fact, the World Health Organization recommends midwives as the first-line providers for the 87% of pregnancies that are healthy and low risk. So shifting the model of care is critically important because women are making it clear that their needs are not being met. We need to make it a priority to increase access to these options. How do we define the midwifery model for other people who aren't as familiar with it? The midwifery model encourages and supports the pregnant person in achieving the care that is best for them. The midwifery model prioritizes person and family-centered care, care that acknowledges the person's lived experiences, that's individualized, that's informed by the person's values, their preferences, their culture, their experiences, and takes into account the context and realities of their lives. It addresses the whole person in a comprehensive way. That means accounting for the social determinants of health, like housing issues, whether they live in a food desert, whether they have safety issues inside their home or on the streets where they live. It means addressing the entrenched and institutionalized racism, classism, sexism, and other issues that affect health. Providing resources or referrals related to other support services is part of this comprehensive model, like childbirth education, breastfeeding support, psychosocial counseling, and postpartum health education. Additionally, midwifery prioritizes active engagement in care decisions, sharing information in a way that's understandable, practical, culturally appropriate, asking questions of clients, eliciting input to encourage participation in decisions, and finally, and most importantly, honoring and being responsive to clients' voices. You know the saying that knowledge is power? Well, it's not if it's overridden or ignored, particularly when a person is in the vulnerable position of being in labor. There needs to be more than just knowledge to turn it into power. It needs to be engagement. The midwifery model fundamentally approaches pregnancy and childbirth as a healthy, normal life event rather than as an illness, and supports physiologic birth from an evidence-based perspective. And this means incorporating low-tech, high-touch options, many of which have not been valued, protected, or made available in traditional medical settings. So taking this preventive approach can include supporting freedom of movement, offering a range of comfort measures not limited to pharmacological ones, facilitating non-supine positions for giving birth, and really importantly, recognizing the effect of emotions on the physiology of labor. Midwives also explicitly prioritize building trust and respect with clients. In surveys and focus groups, many women identify their close, trusting relationship with their midwife as one of the defining and most valued elements of their care experience. Women feel trusted and respected, and they trust their midwife in return. So that's the model, but why do we care if midwives are integrated into the system? Because midwives are the system's experts in healthy, uncomplicated pregnancy and birth. What does that mean? It means no other type of healthcare provider is educated and trained with the same degree of focus on and attention to healthy pregnancy and healthy birth. So I'm going to walk through what makes midwifery a high-value model. I'm going to use the framework of the triple aim for healthcare improvement. So to take a minute to define that, the triple aim is a key framework for thinking about how to improve healthcare. And it recognizes that to really improve this system, 3 goals need to be aligned. We want to be able to improve health outcomes, enhance the experience of care, and reduce spending. And with the midwifery model of care, you hit the trifecta. To start with outcomes, I want to walk through each of these elements one by one, each of the elements of the triple aim one by one. So I'll start with outcomes and move on from there. So this is a chart of outcomes achieved by midwife-led care compared with physician-led care. Multiple meta-analyses have found that midwifery achieves outcomes as good as or better than physicians, and research has found no area where outcomes are worse for women or for babies. And what you see here is that the midwifery model has been documented to reduce overutilized interventions, including cesarean section, episiotomy, epidurals, and continuous electronic fetal monitoring. At the same time, it increases breastfeeding and improves the experience of care, all while maintaining as good or better outcomes for newborns measured by their APGAR scores, low birth weight rates, and NICU admissions. Midwives get great outcomes by combining the approaches that we just talked about before. Many of the outcomes stem from the practice of midwives reserving interventions for circumstances where they've been demonstrated by the evidence to provide a benefit, where the benefits outweigh the risks of harm and complications. And the evidence comes down to showing that midwives can use interventions more sparingly without generating negative unintended consequences. This is especially significant because these areas where midwives improve outcomes include some of the key outcome measures that are being used in current benchmarking and quality improvement initiatives. So cesarean rates and breastfeeding rates are among mandatory core reporting measures that are required by the Joint Commission, the main hospital accreditation organization. And the Joint Commission measures must be reported by all hospitals with more than 300 births each year. Those 2 measures, cesareans and breastfeeding rates, plus episiotomy rates, are included in the set of perinatal measures that have been endorsed by the National Quality Forum. And the fact that those measures are receiving a lot of attention and have become so high profile means that hospitals are focusing much more on addressing those rates and aligning them with the benchmarks and goals, creating an effective opportunity for change. So I want to look a little bit at some data here. This data is from a subset of the National Giving Voice to Mothers survey, the nationwide survey with 2,700 responses. And we collaborated with the University of British Columbia and Jean Declercq and a number of community-based organizations to develop the Giving Voice to Mothers survey, where we asked people about their experiences with childbirth-related care. The data that you're going to see in these charts that looks like this is all from the Giving Voice to Mothers survey, and it also reflects only data from New York State, just the 759 responses from New York, but it's aligned with the larger data set. These graphs compare data by provider type and reflect some of the ways that midwifery care can lower intervention rates. So what you see is physicians are represented in navy, midwife-attended births in hospitals are in teal, and home births with midwives are the orange bars. What you see in the top graph is that in midwife-attended births, people are much more likely to use non-pharmacological comfort measures compared with physician-attended births. So when women had midwives, they were much more likely to be able to utilize alternatives to epidurals that facilitate physiologic birth. And some of these measures are related to the location. So if you're in a hospital and you don't have a tub in a room or even have a shower in a room, then obviously that's going to influence whether they're utilized. But some of these aren't location specific. Any provider can facilitate position changes, warm or cold compresses, or massage, another touch. But you see that across the board, midwives are much more likely to than physicians. On the bottom slide, you see that midwives are also considerably less likely to be perceived as pressuring their client into having an intervention. This is really important because provider coercion doesn't just influence the person's experience of care, it affects the interventions that they actually receive. So listening to Mothers 3, a separate survey, nationally representative survey, found that women reporting pressure to have an induction were 3.5 times as likely to have been induced, and women who felt pressure to have a cesarean were 5 times more likely to have had a cesarean, and 6 times more likely to have had a cesarean where there was no documented medical basis. See here that in this data set, midwives in all settings are less likely to be perceived as pressuring their client to have continuous fetal monitoring, to have a cesarean, to utilize an epidural, to have an episiotomy, or to use other types of pain relief. Overall, many people in the United States report feeling dissatisfied with their childbirth care. They report having insufficient information to make informed and healthy choices. They feel that their concerns, values, preferences, and even decisions are often disregarded. And especially when significant care decisions need to be made during labor, feelings of confidence and control over decision making strongly affect how the person perceives their childbirth experience overall. Childbirth rarely progresses as planned. And when circumstances change or significant care decisions have to be made during labor, communication with the provider influences the decisions that are made, the confidence in the decision-making process, and ultimately really is a driver of how the family perceives the childbirth experience overall. And people cared for by midwives report more positive experiences of care, better communication, greater engagement in decision-making, more control than people seeing other provider types. All of these are key factors in women's satisfaction with their childbirth experience. So this chart reflects how women perceive their decisional autonomy, looking at it by provider type using a scale, a composite scale based on a series of questions about decision-making capacity and control. And you see that looking at this composite score, women whose providers were midwives, both in the hospital and at home, rank their decisional control much more highly than physician patients. That means that they answered positively about having the information they needed, the time to make decisions, and that they felt that their decisions were actually driving the actions that took place. Decisions were not wrested out of their hands. Clients of midwives are also less likely to report disrespectful or coercive care. The top graph shows the percentage of respondents who rated their provider highly for preserving their respect, their dignity, and their privacy. Clients of midwives are more likely to rate their provider highly for protecting each of these important components. And that holds true for midwives both in a hospital and in a community setting. The flip side of that is that when looking at people experiencing disrespectful behaviors by place of birth and provider type, people who were seeing physicians for their care were between 1.5 and 4 times more likely to experience one of these disrespectful behaviors compared with clients of midwives. And the difference is pretty dramatic. So we're looking at whether the person reported their physical privacy being violated, whether they reported that their provider ignored or refused their requests for help, whether they were shouted at or threatened. Thankfully, those numbers and percentages are fairly low. However, the discrepancy is noteworthy. Midwifery's positive outcomes hold true in all communities. And it's important to note that they're also observed in underserved communities. Some of the data suggests that increasing access to midwives can be an effective strategy to improve health equity. These charts show the number of disrespectful behaviors that women reported experiencing per 100 births. And it's categorized by race and ethnicity. So white women are represented by the navy bars, Latino women by the teal, and Black women by the orange. And when you look at the provider type separately, you see an interesting distinction. So the left chart is the numbers of disrespectful behavior reported per 100 births for clients of physicians only. The chart on the right is the same measure for clients of midwives. Women who identify as Black report 50% more disrespectful incidents with physicians than do white women. But contrast this to women seeing midwives on the right screen. All of the women report significantly fewer numbers of disrespectful incidents. But also, the disparities appear to be erased. There were slightly fewer disrespectful incidents reported by Black and Latino women, but the differences are not statistically significant. What's interesting is we identified the same pattern based on income level. Economic disparities, as well as racial disparities, in respectful treatment for physicians are observed with physicians, but no economic or racial disparities are observed with midwives. That holds true when you're counting in the aggregate. So how do costs figure into the equation? Certainly, I'm not here predominantly because of an interest in reducing the cost of care. And I know that none of you have gone into nursing or midwifery because you're primarily interested in the money issues and finances. But it is really important because it can be a significant lever to use when working for change. So, how do costs figure into the equation? Maternity care accounts for the largest share of payments to hospitals, with Medicaid covering nearly half of all births in the US. And these costs have skyrocketed. Between 1996 and 2013, hospital charges alone for childbirth care have tripled. Hospital charges today are 3 times greater than what they were in 1996. And one of the key contributors to this is something that we can do something about. It's the rapidly and precipitously rising intervention rates that are a key contributor to this. Cesarean rates, as I'm sure you know, have risen over 50% since 1996. In 1996, cesarean rates were around 20%, and now they're around 32. 1 in 5 women used to have cesareans in 96, and now it's 1 in 3. And when I was born in 1970, it was about 1 in 20. Oh, I shouldn't have told you when I was born. Why is this contributing so dramatically to the costs skyrocketing? Because the costs of cesareans are 50% more than vaginal births on average. It's 50% higher in Medicaid and 50% higher in private insurance. And so the impact of that is really substantial. So expanding the midwifery model has the potential to contribute to short-term and long-term cost savings. One of the big drivers would be this immediate savings from reducing cesareans, the immediate associated costs with that procedure alone. But also, there's a tremendous opportunity for longer term cost savings that can be a little more complicated to calculate, but are very real nonetheless. Cost savings would be achieved by reducing preventable complications and chronic conditions that result from cesareans. We know cesareans increase the risk of severe life-threatening complications and chronic conditions, and that can result in a lifetime of increased medical costs. So reducing the use of cesareans would reduce spending on these long-term adverse effects. Also, you could achieve savings from reducing repeat cesareans because 9 out of 10 births following a cesarean are repeat cesareans. So avoiding the primary cesarean prevents future surgeries. It has a snowball effect. There would be cost savings for reducing the use of epidural analgesia and complications of that by offering non-pharmacological options for comfort measures in addition to epidurals. Also, there's the beneficial impact of increasing breastfeeding rates, which improves the health of women and infants and results in long-term healthcare savings for both. How do we know we can reduce cesareans? Because of the wide range observed in hospitals, varying by a factor of 10, and because of the results achieved in, for instance, birth centers. Hospitals can't do it overnight, but they can definitely ratchet down these rates over time. Right now, the overuse of routine procedures that people don't need is a misallocation of resources, and it has serious consequences because not enough money is going to prenatal care, not enough money is going to postpartum care and support. At this point, 4 out of every $5 spent in the entire episode of care, maternity care, from prenatal to postpartum, 4 out of $5 is spent in the brief window of hospitalization, as opposed to the 8 or 9 months leading up and the weeks following. Medicaid and private insurance spend more money on maternal and newborn hospital care than for any other category of hospitalization. With Medicaid covering half of all births in the US, how much of a cost difference would this make? Well, the estimated cost savings, if we reduced cesarean rates to 1996 rates, could reach $5 billion. That should be incentive enough for people for hospitals, for payers, for our communities to really think about investing that money not in overused, non-beneficial interventions, but in the services that people really need to support them having a healthy pregnancy, like childbirth education, like home visits if they need that, like nutrition education, psychosocial counseling, likewise lactation support in the postpartum period, as well as other services. We could shift that spending from those unneeded cesareans where it's causing additional complications and take it and using it for these much more beneficial services that have no risk of harm. So this brings us back to the question of limited availability. Why on earth is the midwifery model not more widely available? Well, the good news is that it's going up. It's the highest rate in 25 years. But let's look at really what the barriers are to the availability of midwives. To increase access, we're going to have to identify these barriers and really think through systematically how we're going to work toward change. I'm going to walk through some of them to give you a sense of where some areas are, where changes are needed, and where there are opportunities to move the dial. So first, in terms of availability, one of the big issues is there simply aren't enough midwives yet for all women to have access to one. There are serious provider shortages in this country, and one of the problems is we're facing shortages of all kinds of maternity care providers. Nearly half of all counties in the US have no obstetricians, and more than half have no CNMs. Right now, though, it's also impossible to identify all of the maternity provider shortage areas, also called maternity care deserts. They go unrecognized because obstetricians are counted in the same category as primary care providers, so it's hard to identify where maternity care is exactly it's not available, and likely it extends even beyond the percentages that we know have no providers because there are providers only providing limited services there. In addition, where providers exist, access to midwives varies widely depending on insurance coverage and location. So just looking at New York City as an example, which is illustrative of many parts of the country, midwives are not available as maternity care providers at nearly half of the hospitals with maternity units in New York City. More than a third of the hospitals in New York State have no midwives. And the variation is really dramatic. So you can see here in this pie chart, donut chart, that 37% of the New York State hospitals have no midwives regularly attending births. At the same time, on the other end of the spectrum, 16% have over a third of their births attended by midwives, as high as 73% of births attended by midwives in certain facilities. And what that shows is it's possible. It's feasible to have these high percentages of midwife-attended births in a facility. It's a viable option when it's prioritized. just like we see happening in many European countries. And we know that there's a significant demand for midwifery that's currently not being met. Also affecting availability is the administrative commitment in facilities, because we need to see that real commitment to make integration work. As one hospital administrator told us, the culture at an individual location can make or break a midwifery practice. At the facility this person works at, the midwives have backup and around the clock coverage, and the recipe for why it works is having a supportive OBGYN chair and having midwives on deck 24/7. We know that hospital environments could be unstable. Robust midwifery services can close or open largely based on the administrative commitment, and sometimes what feels really like fiat. Looking at New York City as an example again, been told by obstetric leadership at 2 facilities that they would love to have midwives apply for privileges. However, an invitation isn't enough to make that work. Examples of successful models include those where midwives are really integrated into the fabric of the department and into the fabric of the facility. It's where there are well-integrated faculty practices, like at teaching hospitals, at hospitals where enough midwives are brought on board to maintain around-the-clock coverage of labor and delivery, and where the relationship between midwives and physicians is well planned to be mutually supportive. Creating a stronger workforce in the long term means increasing the provider pipeline, but expansion of the midwifery education system is limited right now, as I'm sure you all face very directly, by the number of clinical sites available for midwives to complete their rotations. Financial incentives for training medical residents make residents much more attractive to facilities than student midwives. Collaborative education also needs to be a huge priority. Right now, midwives and physicians are being educated in separate silos, and this lack of collaboration in clinical training, in didactic training, results in a lack of understanding of what midwives training is, what their scope of practice is, what is their approach to care, what are their skills. And for one example is that in New York City, both Columbia University and New York University have both midwifery programs and medical schools. But neither Columbia University Medical Center nor NYU Langone Medical Center have midwives who currently hold admitting privileges or attend births. Physicians can be trained through those medical schools without ever working with a midwife. In other obstetric resident programs like SUNY Stony Brook and in many other states, obstetric residents are trained by attending physicians and midwives who together oversee part of their training, and they become familiar with the midwifery model of care, and that has a lasting effect on how those physicians view midwives. Experiences as a student can have a lifelong influence on professional attitudes, and interdisciplinary training would have a considerable impact on increasing and enhancing collaborative styles of practice. There are also significant challenges in diversifying the workforce. This is a pressing need. The midwifery workforce remains more than 90% white, even though midwives serve large numbers of people of color. The midwifery workforce does not reflect the diverse communities that it has historically served, despite the fact that families and midwives recognize the particular benefits of midwives of color providing care in communities of color. Those numbers are changing, but very slowly. Among newly certified CMs and CNMs, 14.5% are people of color. Student midwives of color, though, remain underrepresented. On the other hand, the numbers and proportions are slowly rising. Midwives can better meet the needs of the public when the workforce reflects the population it serves for many reasons. Health professionals of color and those from underserved communities are more likely to work in communities facing health disparities. And women in historically marginalized communities report that having healthcare providers available who reflect their identity is of great importance to them. And research shows that patients who view their provider as similar to themselves report higher ratings of trust, satisfaction, and uptake of provider recommendations. Also, we know that there are a number of barriers imposed by insurance companies. Challenges to engaging a midwife can begin with trying to find one. An ACNM survey of health exchange insurance plans found that nationally, 1 of every 5 insurance plans did not contract with CNM/CMs at all. 10% of insurance plans that contracted with midwives didn't list those midwives in their provider directories. So there's no way for women who are looking for a midwife to find one. 40% of plans who do list the CNMs or CMs in provider directories lump them under the category of OBGYNs. So if you are seeking out a midwife and are looking for a midwife, you may not be able to find them hidden in the OBGYN category. And particular types of midwifery services are often included from insurance coverage. For example, primary care services are not covered in 17% of the health insurance plans surveyed. Also, there are some other restrictions. For example, 14% of plans imposed restrictions on CNM/CMs that were more stringent than the legal scope of practice in their state. For example, requiring written practice agreements, even in states where that requirement is not in place. There also are particular reimbursement barriers related to Medicaid and insurance. Low reimbursement rates are really affecting the financial feasibility of independent midwifery practices and mixed group practices with physicians and midwives. ACOG supports equitable reimbursement for midwives and physicians so that they're reimbursed at the same rates, but outdated policies in some states and practices of some insurers allow midwives to be reimbursed at just a percentage of what the physician would receive to provide identical services. At the same time, reimbursement rates for maternity care services have been falling, and there's a tremendous concern that the falling reimbursement rates may force private practices to close or and we have seen that happening in New York City, for example, and New York State. Regarding out-of-hospital births, many insurance plans have no in-network out-of-hospital providers, and many insurance companies at best reimburse for just a subset of the costs for birth center or home birth care. Looking at this chart, I just want to show you here, this is some of the tremendous variation that you see in Medicaid reimbursement by state. And you can see these numbers are for the provider rate for the entire episode of care. So in New York State, for instance, midwives are reimbursed $1,463 on average for 8 months of prenatal care, labor and delivery, and a postpartum visit. Just going to go quickly through some of these because I see that time is moving forward. Other barriers include limitations to providing full scope of care, variations in that by setting, a lot of situations where midwives are providing some services like intake and triage, but not being able to perform full scope midwifery services or practice to the top of their licensure. We also see in a lot of hospitals, there are practices that really restrict people from functioning the way that they're trained, really practicing the midwifery model. So the low-tech, high-touch approach of the midwifery model, we know, is at odds with a lot of hospital cultures. To move forward, we really need to see collaborative practices developing and becoming more common and becoming really the go-to answer. But this is going to require addressing changing physician attitudes and knowledge and getting the buy-in and prioritization from facilities. It's going to really require integration of practices, practice styles, and developing trust between providers who may not have a history of working together. So at this point, looking at some of those barriers, after going through the evidence behind midwifery as a strategy to achieve high-value care, you can start to think through what the best strategies would be for persuasion. If you want to be heard and you want to make progress, it works best to find what is going to resonate with your specific audience. Talking to hospitals about reducing cesareans, you're going to look at different levers and talk about different issues. They have different incentives than payers do, which are different from communities. You always want to be able to anticipate the opposition. Who's going to oppose your goals? What are those arguments going to look like? And this is really important because we know that policy efforts can either expand access to midwife services or further hamper it. We know this because in states where regulations support the practice of midwifery workforces are larger. Midwives attend a greater proportion of births. We know this because communities have successfully mobilized to reopen maternity units and midwifery services. We know this because we have seen new hospital midwifery practices open, with healthy staffing practices and robust collaborations among clinicians. We know this because just this week, we saw Senator Cory Booker from New Jersey introduce the Mommies Act, Maximizing Outcomes for Moms Through Medicaid Improvement and Enhancement of Services Act, which would extend and enhance Medicaid coverage, especially in the postpartum period, and it would increase access to better and more comprehensive models of maternity care. Just yesterday, there was a hearing in the House of Representatives on the Preventing Maternal Deaths Act, which has bipartisan support and would expand support for maternal mortality reviews. In California, this week, 2 new laws were signed into law to improve care around peripartum mood disorders. There are a lot of opportunities for change, and what I want to wrap up with is leaving you with the challenge of finding an opportunity for change that you want to lead, or be part of. And this isn't just a cop-out of my not wanting to give you solutions. We do have a list of recommendations at the end of our Maximizing Midwifery report on Every Mother Counts website. So you're welcome to take a look at that. But the changes that you see in your community, the questions that keep you up at night, the issues you can't stop talking about with your friends, your classmates, your families, your colleagues, that's where you'll find the challenge that you should take on. Don't get me wrong, there are no simple or easy fixes to this, but we're all in it for the long haul. With each year, the percentage of midwives is going up, the percentage of midwife-attended births is going up. So we must be doing something right. And I want to close with this slide of some amazing advocates for midwifery care. This is a picture from just a couple of days ago at the International Confederation of Midwives Champions reception. It was held during the UN General Assembly, and I had the privilege of being there with Sally Pearman, the Chief Executive of ICM, Her Excellency Mrs. Choyan Saraki, the Goodwill Ambassador, the Global Goodwill Ambassador for ICM, Dr. Edna Adan, who is a midwife herself, the director and founder of the Edna Adan Maternity Hospital in Somaliland, and a tireless advocate for midwifery. Christy Turlington Burns, who you met at the beginning, the CEO and founder of Every Mother Counts, where I work, and Franca Cadet, the president of ICM. One more inspiring than the next. And each of these women are working tirelessly to bring quality care by midwives to more people around the world. So I hope that this leaves you feeling empowered to change the system that's in place, because the impact of your work is tremendous. And the country is beginning to focus more and more on the maternal health crisis in the US. And we need to make sure that people know that midwives need to be part of the solution. It's not always easy to practice midwifery. The system isn't always fair, but your voices are strong and powerful. To decide to become a midwife means you've already chosen the path less traveled by. You have a lot of answers. You know what works. So bring it out there, because women need it, women are demanding it, and women love it when they get it. Thank you very much.